this time. For years, for the last few years, we have fought against communicable disease, but the country is currently now, there is the epidemiological transition of the disease shifting from communicable to non-communicable disease. Currently, non-communicable disease accounts for 50% of death in Bangladesh. Among the non-communicable disease, cardiovascular disease remains the top of the cause of death. So Bangladesh has to overcome this burden of health service. In this regards, you will be glad to know that there is a impressive as well as acceptable improvement in the health sector of Bangladesh, including interventional cardiology. And now the government sector as well as private sector of Bangladesh, they act hands in hands to develop the overall health services of Bangladesh, especially giving emphasis on interventional cardiology. Dear colleagues, Bangladesh Society of Cardiovascular Intervention always inspires these sorts of academic activities where knowledge, skill and technology sharing take place between the local and international fellows, faculties and legends. The SCAI always look forward to developing the skill of interventional cardiology in Bangladesh. I wish this 2 days course organized by SCAI Bangladesh along with Bangladesh Academy of Cardiovascular Intervention will give the opportunity to all of us to exchange the knowledge in the field of interventional cardiology. SCAI Bangladesh is an exclusive and interesting learning platform in the whole of the world. We are lucky enough we get this opportunity of this platform to exchange the knowledge between international faculties and national faculties. I wish the success of today's program. I thank everyone, and I also especially thank the international faculties who have joined this program from different sides of the world. Special thanks to my Scientific Secretary of Bangladesh Society of Cardiovascular Intervention, Professor Imam, and his colleague who arranged such a scientific program in Bangladesh. May Allah bless us all. Khuda Hafiz. Joy Bangla, Bangladesh Chirojubiya.
Thank you, sir. Professor A.K.M. Fazlur Rahman, President, SCAI Bangladesh. Now, may I request Dr. Sanjay Talra, whether he's here? Oh, yes, he's coming. So his piece on state of the art, what is complex SCAI and what are the skills that I need? So Dr. Sanjay Talra, his intervention partner is from Canada and giving the piece on art of the state. Thank you.
Thank you, and good morning to my dear colleagues and friends. It's always a privilege to be here in Dhaka. As I've told you many times before, I consider it my own, and so I thank you again for the opportunity to see you all. Over the next 20 minutes, I have the privilege of describing what, in my mind, complex PCI means, because the truth is we don't really have a great definition that's universally accepted across the world. And so what I'd like to do over the next few minutes is try to convince you of what my concept of this is and maybe stimulate some discussion amongst our colleagues here to see if we can flesh out some of the additional details that perhaps are relevant in this market. These are my disclosures. My slides up? I don't think they're up. Maybe I'll wait until we put up the slides. There we go. Okay. That way you can look at the useful information on the slide instead of me, which is not that useful. So these are my disclosures. So this is the lay of the land, right? What do we do every day in the cath lab? We're not doing all that many urgent cases anymore. The number of cases that we're doing in the high-risk PCI realm, those with bad angina, with complex anatomy, who have been previously failed, these are the cases that are going up. And it's not a surprise. It's because we see that the number of calcified type C lesions are going up. the amount of calcification that we see, the average age at which patients present for intervention is later and later. So they have more time to accumulate coronary disease and more time then to develop complexities that then we are charged to treat. This bears out when you look at the nature of the patients in the cath lab. The amount of comorbidity that they have, as measured by the Charlson Comorbidity Index, has gone up over the last 10 years, so that the number of individuals with CCI scores of over 3, this is the group that's considered severely comorbid, has tripled since 2004 to 2014. So we're dealing with a sicker and older group. And that's why it doesn't surprise you that when you look at this study of the Framingham risk category, the risk categories look very similar, but the ages have actually changed over a standard deviation from 2009 to 2015. So our patients are older, they're sicker, and they have worse anatomy. So it's not a surprise then that we are sort of starting to develop programs to treat these types of patients in a dedicated fashion, because we recognize that they require more than our usual run-of-the-mill wire balloon stent approach. But what does this group actually look like, right? We've all seen this Venn diagram before, right? Where we combine the very advanced aging comorbidities with the poor heart function characteristic and the complexity of coronary anatomy and distal targets. And then where these three things combine is where we talk about the complex and high-risk PCI patient. What's the prototype? What can we use to serve as an example of a high-risk PCI patient? And one of the ones that I submit to you is a good example is the surgically ineligible patient. So this is not necessarily the patient that says, I don't want surgery. It's the patient where your surgeon assesses the patient and says, this is not someone whom I feel I can provide revascularization to in a safe and durable fashion because of the variety of things that they have going on with them. And when you suss this out, why does this actually happen? What we see is that in only half of these patients, it's because the surgeon can't graft them as a result of poor targets. The other 50%, so half of the people that we're dealing with, are because they have advanced age, or insufficient kidney function, or severe lung disease, etc., etc. That's what makes these patients quite high risk. It's not just the fact that their coronaries are nasty, it's because working on them requires an additional skill set that goes beyond the technical aspects of what we do to actually patient care, right? Systems of care. When to involve a CCU, when to transfer the patient to the CCU. Do they need hemodynamic support and for how long? And the proof is in the pudding here. When you take the surgically ineligible patient and you follow them out, their in-hospital outcomes are 6 times worse. They do 6 times higher on the mortality scale than individuals who are accepted for surgery. So clearly, this is a high-risk group. So is this complex and high-risk PCI then? Is this what that means? So everybody with advanced age and everybody with a bleeding risk and everybody with CKD and everybody with a left main is complex and high risk? Does that mean that if you're not a chip operator or a complex high-risk operator, you shouldn't touch any of these things? The reality is these are an amalgam of characteristics, right? These are the colors that we put on the painting. But it's the painting together that allows us to understand what we're looking at. So these are characteristics. These are not individual procedures. That doesn't mean every time you do a CTO, you're dealing with a complex and high-risk case. Or every time you do a left main, this is a complex and high-risk case. It's about putting together all of these pieces to develop the gestalt that helps us recognize that this patient is going to need our very best, both technically, from a technological perspective, and then of course medically afterwards. So what's the target, right? So if you have a complex and high-risk patient, what's the target for these individuals? What are we trying to achieve? Well, it's the same as everybody else, right? We know that incomplete revascularization is not good. You know, amongst patients who get in multivessel disease, CABG versus PCI, the ones that do the absolute worst are the ones that get PCI and get PCI of only one target when they've got a ton of disease left behind. And so when you look at individuals who receive complete revascularization over large data sets in the United States, who've had experience with recurrent and repeat interventions in multiple territories, even if you look at large trials like Syntax, you see that those who get complete revascularization tend to do better than those who don't, right? And when you analyze the revascularization, you can define what you're actually trying to shoot for. This was an analysis that was done in the Acuity trial by a good friend who developed this idea of a residual Syntax score. And what we try to shoot for is this residual syntax of less than 8, where then when looking at primary outcome of death at just over a year, your outcomes are very much surgical when you look at residual syntax scores of less than 8. Right? So complete revascularization is where it's at. And that extends to myocardial infarction and all of these other secondary metrics. So if we're really trying to achieve complete revas for everybody, then whether they're complex or high risk or not complex or high risk, the bottom line is the indications for the case don't change just because it's harder to treat, right? So we then have to shore up our very best skills to be able to provide the care that these patients need. So, as I said before, what's the target? It's the same as everybody else. When you can demonstrate the benefit of complete revascularization for a subset of patients, so not your 96-year-old that does absolutely no activity who's already outstripped their lifespan, but your 62-year-old with an ejection fraction of 20% viability in multiple territories, multivessel coronary disease, a CTO, and maybe an LV thrombus, absolutely they need complete revascularization, and it's our job to figure out that, right? So that's the first part. So why then specific training? What is the skill set that we need? Well, I submit to you that this case, which is a CTO of an LAD and a low EF on an Impella, versus this case, which is on ECMO and a left main trifurcation and a patient in shock, versus this case, which is a lung calcific CTO PCI, are 3 different cases. And 3 different cases may be done very differently by 3 different operators, because not every operator or not every bit of training is equal. Right? We cannot expect ourselves to magically do everything. I know that there is an aortic valve and that the word aorta starts with A, but that's about where I stop when it comes to TAVR, because that's not what I do. I have accepted that about myself. So instead, I focus myself on this area of training, and I encourage those of you who are interested in this space to do very much the same. And when you look at this graph from the syntax trial, this sort of illustrates that point quite clearly, where I submit to you that whoever this is in this hospital probably doesn't want CABG. Right? With a 30% MACE rate. No more than whoever it is in this hospital wants PCI with their 50% MACE rate in this trial, right? And everything in between, right? So if every operator and every case and every patient is not equal, then what is complex and high-risk PCI, right? We just discussed how this is a set of characteristics, a set of colors that make together a picture that we view as an indicator of this patient's going to need my best. So when we think about this, then we have to recognize that this is not actually a procedure. Okay, there is no such thing as complex and high-risk PCI. There are patients who need the best skills that we have to offer to be able to achieve the best outcomes for them. And so really, complex and high-risk PCI is not about a procedure. It's about a union of skill sets. It's about how these skill sets are then woven together into a tapestry of other smaller, more individual skill sets. And together, these become complex and high-risk PCI. So not every case is going to utilize calcium management or atherectomy, but I submit to you that if that's a retrograde CTO PCI in someone with an EF of 20%, who then has a big blowout in the leg and bleeds, that's very much a complex and high-risk PCI. And you then thank your lucky stars because you have all of the skill sets around this wheel, this entire complex and high-risk PCI skill set, to be able to provide that patient the care that they need. And so, why training? Why volume? Well, we know from these data out of Progress, using the CTO PCI group, that as you do more work, as your volume goes up, your success rates go up, and your complication rates go down. So there's a theme here about practice and about concentrating skill sets and volume into environments where the best care can be provided and where idea exchanges can happen, like in this meeting, so that we all learn from one another. So how do you acquire the skills, right? Today's training has 2 pathways. There's the dedicated chip training pathway, or there's the on-the-job sort of emerging leader pathway. The dedicated fellowships are great. Right? They give you a unique flavor at every site that you go to. The problem is, there are not very many of them. Right? There's only a small handful across the United States. I have one in Canada. There's one other colleague that had one in Canada who's moved into the US, and they're starting to start them in Europe. There really aren't that many outside of them. And so that really limits our accessibility to this training paradigm. And that's why it's so important then to develop a training paradigm for all of us in this room, right? Who are already on the job, who are doing these types of cases on a regular basis, but who wish to advance that skill set that they have into this tapestry that we discussed, to allow them to be capable of developing novel therapies and delivering the therapies that our patients need. Doesn't matter what walks through the door, right? We are needs agnostic. We are skill set focused, right? Whatever the patient needs is what we provide. And so to understand then where we need to go, we've got to learn from where we've been, right? This is a learn every day, but especially from the experiences of others. It's cheaper, right? Learn from what other people have done wrong. So this is the trauma surgery textbook. This is how you make a trauma surgeon, right? You have an acute care surgeon that's made up of someone who's trained in trauma, trained in critical care, trained in emergency surgery. And so those three, that knowledge base plus the technical skills, plus being in the right environment,